So, Dr. Ritesh, I have already live streamed it on YouTube. You can start when you want. Thank you.
Perfect, perfect. Yeah, so all of you who have joined, can you please give a very small introduction so that I'll be able to call out, and because this is a case-based mock discussion, so there's no point just listening to it, so you have to participate. So for very short time, can you all of you unmute and just introduce yourselves?
Sir, I am Dr. Nejla. I am from India. I work in Kerala.
Okay, okay, perfect.
Hello, sir. I'm Dr. Heba from Egypt.
Good morning, Mariam Fathi from Egypt.
Okay.
Hello, I'm Dr. Asma from Pakistan.
Hello, I'm Mariam from Karachi, Pakistan.
Hello,
Mahmoud
I'm
from
Aina
Egypt.
from India.
All right, so I think we have few volunteers, so let me start. So those of you who don't know me, uh, I am Dr. Ritesh, and I am an oculoplastic consultant, and I'm working in a medical college in North India, that is Ludhiana. And I did my FICO in 2019, the FRCS in 2022, and then I did my IC Ocular Oncology Fellowship in Kellogg Eye Center, University of Michigan. And currently, I'm doing a clinical and research observership in oculoplastics in Milan. So all these international fellowships were possible because of my FRCS. And I did my FRCS just by chance because I had time when I joined my hospital. I was, not very busy with patients. So I could spare some time for the FRCS. And just by doing it, you make connections and you get to know people and, you get opportunities. So I want you to focus on what is your goal, what is your long-term plan, why are you doing FRCS? Like this will motivate you every day to do better. Now, oculoplasty is a very challenging subject. One, because you don't see many patients in the clinics. It's very different from intraocular surgery. It has different set of instruments, different set of skill set to do orbital surgery as compared to retina, cornea, or the cataract. And the decision making is slightly different from intraocular surgery. So it is very difficult for me to get over everything in oculoplasty. But the most important topic which I feel for the exam, whether it is OSCE or whether it is the clinical exam, is ptosis. So you have to be very thorough with ptosis. All the case scenarios you have to prepare in your mind beforehand. What patients you can get, what are the scenarios that you can encounter in the exam. So in the exam, it should be just on your tips, like what is the case and how I have to manage this case. And recently, what has happened is that FRCS exam has included lacrimal system in their clinical exam. Before 2022, I could not see any DCRs or any punctal stenosis or any epiphora cases in the exam, but recent case experience, the FRCS experience has told us that they are keeping lacrimal system in the exam. So you should know DCR through and through. It is now the most important topic because all the topics have become repetitive, but this is something new that they have, started keeping in the exam. And for the other things like eyelid neoplasms, proptosis, and anophthalmic socket, which are again very challenging and very confusing, there are videos which I have shared in the group. So you can go through them, and if you have any questions, then you can put on the group and we can, tackle those situations. So first we will start with doses, and I would like any volunteer to, start with the first case. It's just a, mock exam, so just be very confident and very clear.
Okay, doctor. I'm Dr. Heba.
Okay. Okay, Dr. Reba, yeah. So now you have
So
this
now in
2-year-old child. Yeah, so this can be kept either in the OSCE or in the clinical exam, right? So they are unlikely to keep a 2-year-old child, but you may get, right? So we are going through each and every scenario one by one. Right? So this is a 2-year-old child, and just tell me what you see in this case, and then we will move on to the questions.
okay, first of all, I can see this is a child with unilateral ptosis. Or I cannot judge it. It may be bilateral but asymmetrical. It is more severe in right eye, encroaching the visual axis. I look for any signs of scar, any proptosis. I'll examine I'll inspect the pupil if there is any anisocoria, and I'll ask for if there is any glasses.
Okay.
And if there is any, I'll notice if there is any abnormal head posture for this patient. After that, I'll tell the examiners that I want to measure the ptosis, and I'll measure the palpebral fissure, and in this case, I'll measure marginal reflex distance 1, but it will be by minus. And I'll measure the elevator excursion by putting my thumb on the medial two-thirds of the eyebrow. And first, I'll ask the patient to look down, and then I put my thumb in the medial two-thirds of the eyebrow, and then I'll ask the patient to look upward as much as he can. I don't. I'm not sure about this examination in a child like this will work or not. Um, and after that, I wanted to do the pupil reaction. Uh, I wanted to do extraocular motility. Before that, I want to examine the patient for Marcus gun. I'll give the child any chewing gum or something like this, and ask him to chew it to look for Marcus gun. And I'll inspect the pupil for Horner syndrome, and I'll exclude signs of blepharophimosis ericanthus inversus ptosis syndrome. It doesn't appear in this child.
All
Okay,
right, so
and
let's just pause here for a minute. So you have covered most
lastly,
of the things in
I'll ask for if I can do corneal sensation, and I'll elevate the left lid and look I'll elevate the right lid and look what will happen to the left lid. That's
Okay, perfect. So you have, covered most of the things, and I would expect everybody to know how will you do the examination, what are the things that you need to see, like the MRD, the palpebral fissure height, how to check levator action, the Bell's phenomenon, the Marcus-Gun jaw wink. So this is a very critical part of your examination, and all of you must be very, very clear with how to proceed in this case, right? So this is a child, this is difficult, I know, but whatever you have said is correct. Now, you have told me about the examination. So what are your concerns in this patient? Like, what are you worried about that the pupil is covered, and what will you explain
I'm
to the
worried about amblyopia. Yes, I'm worried about sensory deprivation, amblyopia. So I'll do a refraction for this patient because most of these patients have meridional also amblyopia, refraction error. So I have to give the patient his corrected glasses and to treat amblyopia first.
Correct. So in this patient, our main concern is to prevent amblyopia. It is not a cosmetic surgery, but it is a functional surgery. So for this patient, when will you advise the surgery? Because this is a 2-year-old now. Yes, Dr. Hiba, can you unmute and can you answer that? When will you advise the surgery for this patient?
Um, for this patient, I'll advise the surgery as soon as possible to prevent amblyopia.
Okay. And how will you decide that what is the best surgical procedure for this patient?
I'll decide the best surgical procedure according to the levator function. If it is less than 4 millimeter, so I'll go for frontalis sling. If it is more than 4 millimeter, I can go for levator resection.
Okay, that is perfect. So in patients like this where the pupillary axis is covered and there is severe ptosis, you would expect that LPS action would be poor. And I'm going to give you a cheat code, which is like if you see the eyelid clearly, like, can you see the contour? Can you see my slides? Like, can you see this patient?
Yes.
Okay, so now see that the lateral droop is much more than the medial droop in this patient. So this is a case of congenital ptosis. When the laterally the eyelid is drooping more than the medial eyelid, you are almost 70-80% sure that this is congenital, this is not something else. If the medial droop is more, then it is something acquired. And if it is straight, then it is very threatening. Then I would look for other causes. Like it never happens that the eyelid is very straight. So the lateral droop, because LPS is very strong laterally. So if the lateral droop is more than the medial droop, it is almost always a case of congenital ptosis, even if you have an adult patient. So you were right. In this patient, we did a frontalis sling, and this is the result post-operatively. So the main aim of this surgery is not cosmetic, but to clear the visual axis. And now if this patient did not have like there is no there is no amblyopia, but if the patient has abnormal head posture, even then you go ahead and do the surgery. So indications of operating a child less than 5-year-old is only if the patient has an abnormal head posture or if he has high astigmatism or amblyopia. Right? So this is the first scenario that you can get in the exam for ptosis. Okay, now I want
So how
someone else
will
to.
one can I ask one question?
Yeah, sure, sure.
This one in this ptosis, like it is severe. Suppose 4 mm of ptosis is there.
Mhm.
In this, when we are doing the LPS resection, how we will decide like how much of LPS resection should be done in this case?
Yes. So see now if LPS resection is only done when the LPS action is good. If the LPS
Yeah.
action is good, fair, or excellent, then I would not expect the pupillary axis of the patient to be covered.
Okay.
Right? So those patients who have a very good LPS action, their pupillary axis would be clear, and I would not go ahead and do the surgery in those cases. And I will wait till the patient is like 10 or 15 years old so that I can correct on the table. I can do under local anesthesia, under sedation, and then give a very good cosmetic outcome. For those cases, the main concern is cosmesis. But for this case, the main concern is not cosmesis, it is to prevent amblyopia.
Yeah, but he
We
is
can
not
do.
using his frontalis muscle. If LPS function is bad, she should have been using the frontalis. But I see that both the eyebrows are equal. So still she
So
can have
now
severe ptosis with the not using frontalis muscle.
this patient is now looking in down gaze. So that is why she is not using her frontalis muscle.
Okay.
Okay.
Otherwise,
Otherwise,
her
they
ptosis
all
would
have a
have been better.
overreaction. Yeah.
Yeah.
Sir, there
Okay.
is no lacrimal gland swelling there, no? It's a X-shaped lid. There is a
No, no, there's
deformity.
no
No.
lacrimal gland swelling. Yes.
Okay.
So the picture is not as because in kids it is very difficult to get a clear picture as you get in adults. So I'm not really sure that this patient, yeah, it looks like this patient has some swelling here, but there is no case of lac. This is a congenital ptosis. So this is just to give you a case scenario, right? This is not to
Okay.
go into ifs and buts and deviate from the topic.
Yeah.
So a case of a child less than 5-year-old with ptosis, this is how you will proceed in the exam.
Okay. Okay.
Okay, so I have different scenarios. Let's cover all of them, and if you have any questions, we can take them. Okay, so now I want someone else to volunteer for this case. Now we have a 14-year-old female with ptosis. Like these photos are clear, and here we can have a discussion like what you see and what are the possibilities.
Okay, I will take this case.
And can you just tell me your name?
Yeah, I'm Dr. Arshi.
Dr. Arshi. Perfect. Go ahead.
So in this picture, I see the face of a female um, having right eye, drooping of the right eye. There is a little eyebrow elevation towards the right side of the right eyebrow, and I see one mark over. Maybe probably it is before the surgery. I can see there is some lid crease. Lid crease is seen. Yeah, and
Yes, sir.
the amount of ptosis looks like moderate to 3 mm because it is in the center of the pupil in the center of the pupil, and yeah, this is on inspection.
Okay.
Then I need to
Okay.
before proceeding for, yeah, you want to ask something, or now I want to go for palpation and measurement of the ptosis. So for that and extraocular movements. So for that in the measurement, I will ask the patient. I'll first check for the vertical palpebral fissure. I'll check MRD1. MRD1 will be from the center of the, when I do Hirschberg test, from the center of the pupil reflex till the upper lid margin will be MRD1. MRD2 from the lower eyelid margin till the center of the pupil. Yeah, and if a pupil is if the center of the pupil or the Hirschberg test is getting obliterated because of the lid, then I'll just lift up the lid and make it in minus where it is visible. Then I'll do the
Okay.
LPS function. I'll put my thumb and stabilize the frontalis muscle and let her not elevate it, the eyebrow. And then I'll ask the patient to look down, and then I'll mark the measurement, and then I'll ask the patient to look up and again mark, and the difference of it will be the LPS function. Then LPS function. After that, I have to check extraocular movements. Yeah, extraocular movements are important. I'll check in all the 9 quadrants if any restriction is there, and pupillary reaction is important. And the other thing I have to check for this patient, the myasthenia. I have to do muscle fatiguability test. I have to do I lift the right eye upper lid and check if the left eye lid is getting drooped because of Herring's law of innervation. If it happens, I have to check that thing also. And other thing is when the patient is looking down, I can see in the third position that the lid is not as down as it is in the left eye. So this mostly happens in the congenital because of the contraction of fibrosis of the muscle. This probably happens because of that, but I'm not sure why it is here. Uh, this is and Marcus Ganjaw. I'll check for the Marcus Ganjaw if there's any improvement because of the disinnervation of the third nerve. And then pupillary erection and the fundus examination I'll do and finish my examination. Corneal
Okay, so this
sensations
is
is also important.
perfect.
Corneal sensation and Bell's phenomena I have to check because if you are planning for the surgery, we have to check that corneal sensations are good and the Bell's phenomena is there, so that exposure does not happen, and leg of thermos I'll do. Yeah.
Okay, so that is good. You have covered all the things, but the only thing I want you to do is write all these steps. How will you examine? Like, how will you start? How will you first proceed with do the Hirschbergs, then do MRD, then whatever is your sequence, just write it down and practice 10 times, because this is the kind of patient you are getting in the exam. They are very fond
Yeah.
of keeping a congenital ptosis, and you will get a patient like this in your exam for sure, some of you. So, what do you
Mhm.
think is diagnosis in this case based on this examination?
Based on this examination, although she's not a child, but if I see the right eye, there is, there's retraction of the lid of the right eye. So I think it can be congenital ptosis because of any fibrotic muscle. And though it is not very clear cut, because I can see there is a lid crease and it's not very clear whether it is a little high or what. This I cannot make it in the picture, but I think so. It could be congenital ptosis.
Well, say it confidently, because this is congenital ptosis. So, improvement of ptosis in down gaze is always a sign of congenital. When she's looking down like this, LPS is not releasing down. So there is, improvement in ptosis. When she's looking up, see the LPS in the first picture here, the LPS action is poor, that she's not able to lift her eyelid. So from the primary position, when she is looking up in the first picture here, see, so there is
Yeah.
almost no elevation of the eyelid. Even we have not blocked the frontalis. Even then, she's not able to lift the eyelid.
Yeah. Yeah. Yes.
So again, same question. So what are your concerns in this patient now? So this is the first time you are
Uh,
seeing this patient.
yeah. And it is moderate doses, and the thing is that the patient is already grown up, so I'm not concerned very much about amblyopia, but yes, I have to do visual acuity, refraction, and this is important. And my concern is, if I do like that, if I do the surgery, maybe the drooping of the other side, I have to explain to the whoever the family members and to her. And I have to check for the corneal sensations, and we have to check that there is no other cause which is causing any decreased corneal sensations. I have to explain that. Then overcorrection, undercorrection also can happen. I have to check her. Um, and I can advise the surgery. This is for the cosmetics reason right now.
So
Yes.
yeah. So you're
Yeah,
doing very well.
cosmetic.
The only one thing that I want to tell you is you will only have 3 or 4 minutes for one patient. So my only question was, what are the concerns in this patient? I have sequential questions, right? So stay to the
Yeah.
point. Like, the only concern in
Okay.
this patient is cosmetic, because she has
Yeah.
grown up, she's going to the school or college. So her main
Yeah.
concern is cosmetics, right? So next
Yes.
question is,
Yes.
when will you advise surgery for this patient now? And how will you
This
decide
patient.
what is the best surgical procedure for this patient?
So the surgery can be advised at any time now, whenever she wants it. It is on her. And I will advise best surgical procedure for this is, since it is moderate doses, and I will decide according to the LPS function. If it is good LPS function,
So you can
then,
see here,
or
the
even if it
LPS
is
is not
fair,
acting, like the LPS action is poor. It is like 2 mm.
2 then I have to use his frontalis muscle. Then I have to go for the frontalis sling operation.
Okay, so the
If
frontal
it
is
is
linked. So now what are the materials that you can use for this procedure?
for frontalis sling, mostly we are using facial lata, proline or silicone. Proline sutures, mainly facial lata is good, uh, because it
Okay,
is
so why
having
do
less
you
allergy
prefer facial
reaction.
lata as compared to other materials that you have?
Sorry, what you say?
Why do you want to prefer facial lata? Like you said that most commonly facial lata is used. Why do you think that facial lata is the most commonly used material for this surgery?
Yeah, because it is organic, and it is like has less allergy, less complications, and it is it gives less chances of rejection, so it will not cause any allergic or hypersensitivity reaction, and well tolerated by the patient.
Okay, so let me put it the other way. What are the
Yeah.
downsides of using a facial?
Downsize. Downside,
What are the things you're worried of using a facial ata?
complications of using facial ata. I don't know. I
Where
think
do
it
you?
was really good.
Okay. So where do you get facial ata from?
From the lateral side of the thigh.
Okay, so you will have to put her to sleep to get a facial ata, right?
Yeah, yeah.
So this will be an added surgery that you first perform on her thigh and then you perform on her eyelid. And what are the
Yes, yes.
advantages of doing this double surgery on her? Like, why do you think this will be the best procedure and best material for her?
The only thing that I think it's better because this is well tolerated, and the sutures are, and the proline sutures and silicone is not her own body's material, so might can get have issues with the tolerance, and it's a lifelong. So I would like to consider the organic material, which is her own, from her own body, like autologous facial ata is better. This is what I think.
Okay, so let me correct you here that most commonly used procedure for this surgery is a silicone sling. Why?
Okay.
Because it is very easy to get, it is very biocompatible, and rarely, like, if you do 100 procedures, maybe one or two patients can develop a granuloma or infection, but 98 of those patients, without having an additional surgery, do very well. I have never done a facial ata in my, I've been doing this surgery for 4 years, but I have never touched a facial ata ever. So there's no
Okay.
added advantage of, the only advantage is that facial ata is a more permanent surgery because what happens with sling, so this is what we were coming to the complications. So what happens with the silicone sling is that it is a rubber band. So whenever she uses her
Mm-hmm.
orbicularis to close her eyes, after some time the eyelid will droop down and you will have to tighten the silicone sling after say 10 years or 7 years.
Okay.
So this is the only
Okay.
downside of using a silicone sling, but otherwise it is as good a material. It is biocompatible, no granulomas, no infections, and you can, it is a reversible procedure. Like if you lose your facial ata once, you will have to harvest it again. So only those
Okay.
patients with blepharophimosis syndrome with bilateral ptosis who do not want any procedure done later, who are from very far off place, they cannot come to you for even a single exam. Those are the patients you might think of doing a facial ata for a more permanent treatment. But
Okay.
anyways, it is not the first. The first choice is always a silicone sling,
Okay.
right?
Okay.
So facial
Yeah.
ata is slightly better only because it is more permanent. It integrates with the other tissue, whereas silicone, it does not integrate with the other tissue and it becomes loose after some time. So this you
Okay.
have to explain to the patient beforehand. Along with the only
Okay.
complication they have is an exposure
So
keratopathy.
yeah, exposure keratopathy can happen, under correction, over correction, and it actually we need to divide it into whether it anesthesia related complications, and we have to divide it into the surgery related complications and post surgical
Oh yeah,
complications.
so
So
yeah, right. So that's what I'm saying, that you don't want to, roam around the bush when you are in the exam and they are
yeah.
asking complications
Okay.
of this procedure. Just say that you can have exposure because that's what they want to hear from you. So first thing on your
Okay.
mind should not be the patient can die from anesthesia. Yes, it,
Yeah.
it could be your 10th complication that patient might have anesthesia related complications. But first thing that you
Yeah.
have to say is I'm worried about exposure keratopathy because you are lifting the eye
Yeah.
and the LPS action is not there and frontalis will keep on pulling up the eyelid,
Yeah. Okay.
right?
Okay.
And
Yeah.
what
Yeah.
are your strategies? And another very important question for the exam is what are your strategies in this case to prevent exposure keratopathy?
Okay, so to prevent exposure keratopathy, my strategy is to check properly pre-op, and assessment should be done very properly to check how much degree of squint is there, and we have to check whether after
No, there's no squints.
after lifting this lid
Just say,
there is
I
any.
want to know that
Yeah.
what will you do after surgery? Like you have, so this is her post-operatively. So when she
Hmm.
closes her eye, the eyelid on the right side, this is 1 month after the surgery. So the eyelid on the right side is
Yeah.
not moving. So she has a
Oh,
lag. So what are your strategies to prevent it? Like tell me, like what will you do during the surgery and after the surgery to prevent any exposure?
so to prevent the exposure, the overcorrection must be looked over. That we should not overcorrect the patient. Corneal sensations should be good, and lubricants has to be given, which is given for the exposure keratopathy. Um,
Okay,
yeah,
yes. So you will
and
prescribe
adjustable
frequent
suture is
lubricants. Yes.
possible in this case. I don't know that one. If adjustable sutures are given, as in we give in a squint, that I'm not sure. But if it is there, we can do that.
No, so there are no adjustable sutures
Okay.
because see, you see this forehead. So we have done a pentagon in this case, right? So there is a very small suture line here. There is a very small stab incision hidden in the eyebrow, one here.
Yeah.
So if you have not watched the frontalis sling video, so there is a sling which goes from here, then this side, then here. So this is a pentagon that we have done. For
Okay.
the
Yeah.
first thing intraoperatively we do is to put a frost suture. So frost suture is a suture taken from the lower eyelid, and this suture
Mm.
is hanging down. So when the patient sleeps, you put this suture up on the forehead so that the lower eyelid is pulled up when she sleeps. So this is done for initially 7 to 10 days to prevent any exposure. So as the sling starts moving, as the rubber expands, then you put her on frequent lubricants and lubricant gels during the night time when there is higher risk of exposure.
Okay. Okay.
Right. So the
Okay.
first thing
So this is
intraoperatively
only
is to
for
put
one
a
week.
frost suture.
Okay.
Yes. So frost suture is initially for 7 to 10 days.
Yeah.
And then you put her on frequent lubricants. And even if
Yeah.
there is slight of exposure, you see an exposure also that is developing, then you can remove this sling. It rarely happens, but if the
Okay.
Bell's is very poor, if your preoperative exam is not correct, then it may happen post-operatively. Yes.
Yeah.
So this is
Okay.
what your viva will be if you have a case of frontalis sling. These are very commonly asked questions. So you should be very clear that what are your complication, what are your concern, when are you doing surgery, how will you counsel the patients?
Yeah. So this
Dr. I have
so this overexposure keratopathy, which is corrected by frost suture, is it because I mean, why it is during in the 1 week of the procedure? Is it because of
So
some edema or something?
there is no edema. So what happens is when you put a sling is extremely tight initially, but because it has not been stretched. So if you stretch a rubber band for 1 week, it will get some action and the eyelid will start moving. But for initial 1 week, it is not moving at all.
Oh, okay. Okay. Okay.
Okay. So
So
that is done for
develop
only 1 week or
elasticity.
10 days.
Okay. Yeah. Okay. 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 Fine. Thank you. Yeah.
So if anyone has any
Doctor,
more
Doctor, I
questions
have a
regarding
question.
sling,
I have a question regarding the first picture of this patient. There was deficiency in elevation, like this. Yes.
oh yeah.
So I have to mention about the monocular elevation deficit syndrome, or this just because of the genesis of severe rectus.
Oh, this looks like a monocular elevation deficiency, but she does not have it. It looks in the picture that the eye is not moving up, but it is moving up. But yes, you have to do in your exam if there is monocular elevation deficiency, you have to mention in the exam.
Is it this ptosis associated with monoocular elevation deficit, or is it because the elevation is LPS and superior rectus action takes place together? I mean,
Yeah.
with
So,
severe
so
ptosis
you can read about
elevation.
Marcus Ganjovin. So ptosis has to
Yeah.
be classified into simple congenital ptosis and a complicated or a associated ptosis with Marcus Ganjovin or a monocular elevation deficiency.
Okay.
or a syndrome like a blepharophimosis. So all those things have a different treatment plan, and this simple congenital ptosis has a different treatment plan. So the case that you will get in your exam is most probably a simple congenital ptosis, but you can get in rare chances a case of monocular elevation deficiency.
Okay.
Sarah, I have a question, please.
Sir, if it is associated with the ptosis also, so we will correct the strain first or the ptosis first?
And this is a very good question. If there is strabismus along with, so first you have to correct the eye in the primary gaze. Do not touch the eyelid before touching the primary gaze. So you have to correct the patient in primary first, and then go ahead and treat the eyelid.
Sir, if it's a severe ptosis and the negative MRD1, how can I measure the MRD1 in the exam?
Or if it is covering the pupillary axis,
Yes.
or then it goes into the negative. So you just elevate the eyelid and see how much elevation you need to do to see your Hirschberg's or the light reflex. So the amount of elevation you do when you see your corneal light reflex is the MRD.
How much I will elevate the upper eyelid?
Yes, the amount of elevation that is required to see your light reflex is the MRD in negative.
Okay,
Till the
just see the
pupillary
light
reflex.
reflex.
Till the pupillary
Okay.
reflex, yes.
If the corneal light reflex, not the pupillary reflex.
Sorry, yeah, light reflex. Yeah, yeah. Light
So
reflex till the pupillary.
be very careful with the words because they are there to catch your words. So you have to be very specific.
Yeah, yeah, true.
Right. So next, move on to the next scenario. Right. So can I have another volunteer for this case? Now we have a 21-year-old male
Yes,
with
sir.
this condition. Yes. So can you tell me your name, please?
Mariam Fatih.
Okay, Mariam, go ahead. So what do you
Okay.
see?
I can see a picture of a young male who has ptosis in his right eye. I'd like to ensure that this is not a pseudotosis, as I can see some retraction of the other eye. And
So why do you say there is a retraction of the other eye?
because the upper eyelid is above its normal level. It should cover 1 to 2 milli from the cornea.
So this is it. This is the picture in primary gaze. So look at this picture.
Okay.
Okay, so left eye seems pretty normal, right? There's no lid retraction in the left eye.
Okay. I can see the lid crease. There is no brow ptosis or blepharoptosis. The pupil looks normal. There is no abnormal head posture. I would like to check the pupillary light reflex. I'd like to check also proptosis. Then I'd like to measure the marginal reflex distance 1 and 2. Also the levator function, the pretersal show, and the skin crease length. Also, I would check the corneal sensations, the lead ptosis of the other eye, and Bell's phenomenon. I'd like to check the cause
Okay.
of this ptosis.
Mm-hmm. Perfect.
Okay.
Okay, so this patient has had a unilateral droop since childhood. So that is the history.
Sorry?
So this patient has this condition from childhood.
Okay, but I can see some limitations in his right eye for abduction in the third picture.
Yes, so this is a case of elevation deficiency. He's not able to lift his eye. So let's not focus on that. Let's just focus on the eyelid in this case.
Okay. I'd like to exclude Marcus-Gunn phenomenon and blepharophimosis syndrome. I'd like to exclude third nerve and Horner. There is no anisocoria or nor heterochromia. I'd like to
Okay.
exclude also I'd like to exclude myasthenia, but it's not common in males. Most probably this is congenital ptosis. So I should
Okay.
check visual acuity of this patient. I should ensure with old photos of his album. Then I should counsel him for the surgery.
I will, I will. Okay, so perfect. So our main concern in this patient is a cosmetic correction. And we have discussed all the examination part, how will you examine? So now this patient has a good LPS action and a moderate ptosis. So what do you think will be the best surgical procedure for this patient?
I think it will be levator resection.
Perfect. So now tell me a little bit about the surgery. How do you perform? What are the steps of levator resection surgery?
Levator resection surgery can be done by cutting an incision in the skin crease, exposure of the skin and orbicularis, then till I reach the tarsus. I will follow the and dissect it, and I will hook it and measure the amount of resection I would like to do with a special.
So how much resection will you plan? Like how will you decide how much to resect?
According to the degree of ptosis, okay, there is schedules for this, international schedule, I think, but I think that 1 milli resection will correct about 2 to 3 millimeter.
Okay, so there is a Burke's rule. You can all read about the how to grade. So this is not, I'm not covering this because this is part of theory. So how to grade ptosis, what are the amounts of ptosis, how to grade the levator action, and how much to resect. That's the Burke's rule. You can read it. It is not used, but some of the examiners are very fond of asking about the Burke's rule. How much will you resect? Okay.
Okay.
Okay, so now I will just show you a video just to make you a little more aware of the surgical steps. So, okay, so what are the complications that you would expect after the surgery?
After surgery, first of all, I should counsel the patient about under or over correction, because this may happen. Complications about the lead contouring, about the exposure, about hematoma can happen. Also, orbital infection may happen.
Okay, so very rare case that you can develop infection, but the most important complication of LPS, or it's a part of surgery that under corrections and over corrections are very, very common. And this is the most trickiest surgery that I have ever, learned. So let's see if I can play this video for you. Okay. So this is not a full length surgery, just to give you the steps that first you dissect the skin, then you dissect the orbicularis. So it is all based on color. So this pink structure you see below the skin is orbicularis. So then you dissect down directly until you see a whitish tissue, that is the tarsus inferiorly and the orbital septum superiorly. Right. So this whitish structure that you see now in the dissection is the tarsus. So you go inferiorly and dissect the orbicularis of the tarsus so as to expose it, to put your sutures through it. Right. So once you have exposed it, then you move your dissection superiorly. So now this red tissue that you see over the, let me just highlight for you. So this red tissue that you see here, so this is the Muller's muscle. So this is a very consistent landmark to identify LPS. So anything above this whitish tissue above this is LPS muscle. So here the dissection is between the Muller's muscle and the LPS. And what I want to show is that you suture this LPS muscle to the tarsus, and then for the contour, you put 3 sutures. And most of the times now, the eyelid height is checked by putting a slip knot. So the Burke's rule is not followed for all practical purposes. It is this slip knot that you pass your suture first, give it a bite through the tarsus, and then check your eyelid height intraoperatively, and then decide that whether you want to excise more or less. So that rule that 1 millimeter will correct this much of resection, that is only done when the patient is under general anesthesia. So when the patient is under local anesthesia, this is the very important step, that you have to check your height intraoperatively, right? And then the lid crease forming sutures, they might ask you to form a lid crease. The suture bites are taken through the belly of the LPS. Like when you are closing, you take your suture bite from the skin orbicularis and then through the belly of the LPS, and then again out through the skin. So this will form a lid crease. So you can take 3 or 4 of these sutures and then close the eyelid incision. And I don't have a post-operative picture of this patient, but this is a selfie that he has sent me. So this is the pre-operative picture and this is the post-operative picture. And there is slight overcorrection in this case. Like on the right eye, you can see that eyelid is slightly more open as compared to the left eye. But he is doing fine, so we are not doing anything for him right now.
Sir, kindly tell us about the suture you used in this very first section. Sometimes they ask about the sutures as well.
Yes, so non-absorbable sutures are used to tie LPS to the tarsus plate. So most commonly used suture is a 6-O proline. And for the skin crease, you can use any suture, Vicryl or a proline, because you're anyway going to remove it on 7th post-operative day. So this suture that you see here is a proline. So it's a monofilament, non-absorbable suture with minimal tissue inflammation.
60 proline, sir.
Yes, it's a 6-O proline suture. So you can use any non-absorbable suture here.
So
Thank
the
you.
thing is that if there is, I want to ask one more question. If there is a little overcorrection on the first post-op day, with the passage of time, this is there possibility of this overcorrection to be better, or if there is a little undercorrection done and it becomes better, which one happens during the consecutive days?
Okay, so in initial post-operative days, slight overcorrection is desirable because you would expect the eyelid to come down as because there are a lot of things in this. Because you're putting a suture, sometimes the suture slips, sometimes the knot slips, sometimes the proline, because in this proline suture, sometimes if you have not tied it properly, you have not tied it 5 or 6 times, it slips. So
Okay.
post-operatively, what is desirable is probably 1 or 2 millimeter of overcorrection. But if you have a larger overcorrection, then you can ask the patient to gently massage over the eyelid for initial 1 month, and you don't do a correction surgery until 1 month. If there is
Oh,
undercorrection, it may be an inflammatory edema. For 2 weeks, you can wait, but if it is not resolving after 2 weeks, you have an undercorrection, you do not you do not have a matching eyelid height, then you have to put your sutures again.
okay. Okay. So we'll wait for 2 weeks in the undercorrection and wait for 1 month in for the overcorrection.
Yeah, so if it's different for different surgeons. If under correction you don't have any, you have a minimal eyelid edema and still the patient is under corrected, you can do a resurgery on 7th post-operative day as well.
Okay. Okay. Fine. Thank you.
Okay, so now I need another volunteer for this case.
I will take, sir.
Yes,
I'm
sir,
Dr.
I can.
Doctor
Nejla.
Nejla, yes, go ahead.
I have to
Now we
answer the
again have
question.
a 20-year-old male. Yeah.
Okay. Keep points in the history taking. I will ask the onset and the progression of the ptosis in this patient and whether
You have now see you when you go into the clinical exam. So this patient is
family
sitting
history
in
of the
front.
ptosis and whether this patient has.
So just tell me from the beginning that all those things that you will see in the all those things you will ask and how will you proceed with the examination first?
The onset and progression, how when it
Okay.
happened and it was gradually progressing or it was staying like that, it was sudden
Okay, so the
onset.
patient will know that. So patient says that I have no idea, like I don't know whether it is congenital, whether it has happened now. There was slight difference. So what do you want to do now?
Then I have to do the examination of the ptosis
Oh no, what about the history?
history, and if there is any family history, whether any family member having this kind of ptosis,
Okay.
and if there is if he's having ptosis since birth and it is whether it is um, gradually worsened recently, that I want to ask.
Okay, progression. Yes.
Hmm. Then any
Okay, so the
previous
most
surgery
important
has
thing is
done any
when
trauma, any
okay.
previous
You
surgery.
you look for scar, any trauma, yes, that is correct. But the most important thing that I want you to know is whenever the patient says, I don't know whether this has happened right now or is this congenital, always ask for previous pictures. This is probably the most underrated and the most skipped step that you don't ask for previous pictures. Sometimes what happens is the patient comes in and says that I have this condition from 2 weeks. But when you see his picture, you will be surprised that almost 70% of the patients land up with a congenital ptosis. They don't know that they have a mild congenital ptosis. This is not a mild case, but just keep in mind to look for previous pictures whenever the history is doubtful.
Okay, sir. Okay.
Okay, so now just look at this picture and just tell me that what do you see?
Yeah, I can see a picture of a 20-year-old male. The right eye, there is a severe drooping of lid. I can see
Mhm.
it covering the visual axis. I can see the lid crease, and in the left eye there is a minimal lid retraction. There is a
Okay, so
minimal
don't say minimal
clearance of.
because there is
Mm,
you cannot grade it. But say there is eyelid retraction in the left eye.
yes,
And also the pupil is dilated, you can see a very good retinal reflex. Okay, so
yes.
there is unilateral ptosis. You have a lid retraction in the left eye. So how will you proceed in this case?
Yeah,
You have
I
done
will.
all your examination. Let's just
Yeah,
skip the examination that you have
in
done
the
MRD1,
examination, I
MRD2.
will do the extraocular movement also, and
Okay.
then fatigability test and this ice pack test, Kogan teach.
Okay, so what is Kogan twitch? How will you do it? How will you elicit the Kogan slit
Ah,
twitch?
ask the patient from the down gaze to suddenly ask to the primary gaze, and I can see a sudden movement of eyelid towards the up, and then it will come to the primary position.
Okay, so this is one. What else? Ice pack test. How will you do ice pack test?
I will ask the patient to close the eyes and put a ice pack over 30 seconds, and again measure the ptosis. If it is an
Why
improvement
do
in
you
the
want to
ptosis,
keep it for 30 seconds? Why? I mean, what is the logic of putting it for 30 seconds?
aspectus is actually positive in myasthenia gravis. When we keep the eyes over the eyelid, mm, I think this acetylcholine receptor does not get blocked.
Or do you do ice pack test in your clinics or you don't do it?
Actually, I have done it before in my PG period.
Oh, okay. Okay, so the you should know that ice pack test is always for 2 minutes. If you keep it for more than 2 minutes, it will cause anesthesia of the orbicularis and you will have a false negative test. So it is for
Okay.
2 minutes, and you have to be very sure that Your ice pack is not on the orbital rim. So what happens is sometimes the ice pack is very large and it sits on the orbital rim, and what you want is on the orbicularis and the LPS muscle. You don't want it to sit on the orbital rim and the frontalis muscle, right?
Okay.
So it is
But
for two
2 minutes
minutes.
is
You have to start the
when,
test.
okay, sir. When I did 2 minutes, the, pa- the patient might complain about the pain because of ice.
Also, you can put a cotton pad or a gauze in between just to reduce, slightly give comfort, but none of the patients complain of pain if you have a good ice pack. Like if there's a specific
Okay.
ice pack for this test. It's not like a
Mhm.
frozen ice, but very small. I don't know what you call it, a balls of ice which are in a sealed paper. So,
Okay.
anyways, it is the main concept is to put it for 2 minutes and over the eyelids and not over the orbital rim. Okay, so next question is what is the sensitivity of the ice pack? What if the ice pack is negative?
Again, if then I have to do the investigation, blood test. Cognitive, if there is cognitive is positive, if I am suspecting myasthenia, I have to do the blood test.
Which blood test?
Acetylcholine receptor, anti-acetylcholine antibodies and musk antibodies.
Okay. So what is the so you need to know the sensitive because this is written in Kansky. So you need to know how sensitive it is the test. How sensitive is the ice pack test?
I'm not sure, sir. I'm not sure.
Okay. So none of the tests, any test is neither sensitive nor 100% sensitive and specific. There's no test for myasthenia which is 100% sensitive. So if you see this case, this is the patient after ice pack test. So it is 80% sensitive and it is very specific. If the patient opens his eye after, and what do you expect? Like how much correction do you expect after ice pack test? When will you say that the ice pack test is positive?
Around 2 to 3 millimeter correction of the ptosis.
Yes. So before and after you should have a minimum 2 millimeter of correction. Only then you will say that it is positive. Right? Then you will do.
Yes.
You rightly said that you can do
Blood
acetylcholine
invest.
receptor antibodies. Musk antibody is almost never done. I mean, there's no point of doing it. It is expensive and it is not available everywhere. What else?
And I will refer the patient to the neurologist for the further examination and single fiber muscle EMG and all to doing
Yes, so
that.
this is the most important test that you need to perform in any case, whether it is a generalized myasthenia gravis or the patient has presented with a ocular myasthenia gravis. So EMG is very important because this gives you a definitive diagnosis and it is very sensitive and very specific test. What about the tensilon test?
Penicillin test is not done usually because of the uh, adverse reaction.
Correct. So can you do something else? So some
Practicability test.
centers are now doing, yeah, so some centers are now doing hydrophonium test, but very rarely you need it if you have everything is, you're suspecting everything is pointing towards a myasthenia, but all the tests are negative. Maybe it is the last resort that you can inject hydrophonium in the ICU setting.
Okay.
But because it is written that you have to mention that this test has to be done.
Okay.
Okay.
Mm.
So you
Okay.
should be be thorough of all the tests in myasthenia gravis. And what
Mm.
about the systemic findings? What do you want to rule out in this patient? Now we have
Yeah.
no, now we know the
In
ice pack is positive.
the thymoma, I have to rule out. I have to do the CT chest if there is any thymoma in this patient.
Okay, so what would you advise? CT chest or CT neck or MRI neck or MRI chest?
No, thoracic CT, CT thorax.
CT thorax, not the neck.
No.
Okay, so you should also be very clear that what you are going to advise. Why a CT over MRI? And how many patients of myasthenia have a thymoma? And this is again written in Kansky.
15%, I think.
Oh, yeah, 10 to 15% of the cases. Yes. Yes, you are right that CT is better in these cases just to do a screening, and then rest surgeons can decide whether they want to do an MRI or not. Okay, so the next question is, what are the causes of variable ptosis? What are the other causes of variable ptosis? If the patient says they have a eyelid which moves up and down, what are the causes that you can think of?
Other causes, Marcus gun jaw winking,
Yes, Marcus gun jaw winking is one.
CPO, contra.
CPO will not have a variable ptosis. It will be progressive ptosis, but not a variable.
Then maybe blepharospasm.
Yes, blepharospasm would be, and other are you should remember the misinnervation syndromes. Like sometimes a third nerve or seventh nerve, when it is misinnervated, it can cause a variable ptosis.
Okay.
Okay,
Aberrant
and then management.
regeneration. Aberrant regeneration of third nerve.
Yes.
Okay, okay.
Or a recovering third nerve sometimes also. And management of the case, as we have discussed, that with
Yeah,
the neurologist.
yeah, with the multidisciplinary team approach is needed. And the periodostic,
Yes.
actually they prescribe pyridostigmine.
Yes, so it has to be in consult with the neurologist because this is a systemic disease. And I have kept this case just because every ptosis is not congenital or acquired. You don't need to perform surgery. You also need to keep in mind that it can be myasthenia or something else, right? And you have to be
Okay.
very, very clear. Every word that is written in Kansky, you should know it by heart. What test, how much test, what is the sensitivity, how much thymoma, what is the percentage, and how will you manage? Right, this is very important. So life threatening conditions are a priority. If you do not do well, this gives a very bad impression on the examiner,
Okay.
right? So Horner's, myasthenia, any emergency, you have to be very, very to the point that what test you will do, how will you do, and how will you manage.
Okay.
Okay, so let's come on to the last case of this doses. So anyone else who want to volunteer for this case?
In the last case, there will be diplopia also. The patient will have diplopia, variable
No,
diplopia also.
so this patient did not have diplopia, so it is not necessary always that patients will have diplopia.
Okay.
All right. So anyone for this case?
Sir, I'll do so.
Okay.
Oh. So this patient, how will you examine and what are your differentials? So initially, I'll start with the history, age of onset, progression. This patient looks old age person. So then I'll check for the looks. After seeing the age, the progression, I'll see the brow. The brows are fine. The lid crease can be seen. There is a high lid crease, and the eyelids are just above, just covering the light corneal light reflex. So it's a moderate to severe ptosis in a old age person. So most likely looks like a case of aponeurotic ptosis, but I will do the measurements before that, like a degree of ptosis, the levator function, and corneal protective mechanisms also, like Bell's phenomena, lag ophthalmos. And so my diagnosis will be a case of aponeurotic ptosis in both eyes, moderate to severe.
Okay. Okay. So what could be your differentials in this case? Like what are the causes of acquired ptosis is the question. Like, this is a patient who is complaining of drooping of upper eyelid since past 1 year.
Okay. So first will be a senile aponeurotic ptosis. Second can be cranial nerve palsy, but third cranial nerve palsy can also lead to ptosis. Third is myasthenia gravis, um, and
Okay.
I cannot see any tumors or anything which can lead to mechanical drooping.
Okay.
Those are my differentials, sir.
Okay. So how will you differentiate this? So I told you like patients sometimes they do not tell you whether it is congenital or acquired. So how will you differentiate this from
So
congenital ptosis?
first, we'll ask for that old photographs to see when is the onset, whether it is of recent onset or actually he's having it from a long time. That is the first thing. And then from the measurements, we'll check for the lead lag in down gaze, whether it is improving on down gaze or it is getting worse in down gaze. And then we'll see the lid crease height is quite high, and then the levator excursion, which will be better in I mean levator function will be good in case of aponeurotic ptosis. But whereas in case of if it is a congenital ptosis lasting since a long time, the levator function will be poor, mostly poor, and then there will be lead lag on down gaze.
Okay. So now how will you manage this case? Like this patient has a fair LPS action and a moderate ptosis. And what you missed here is that he has also the retraction of the lower eyelid. See, the normal position of the eyelid is just touching the limbus, whereas in this patient, the lower eyelid is sagging down.
So we'll say along with it as an ectropion.
Oh, no,
Is
there
there
is no ectropion.
okay?
So this is because of his eyelid bag. So he has a very prominent fat pads which is pulling the eyelid down. So let's not talk about it first. Let's talk about the ptosis. So how will you manage this case now?
So I will once if we have diagnosed this as a acquired ptosis with a good levator, moderate levator function, then we'll give the patient option of whether he wants to improve because of his age, whether he wants to improve the ptosis for cosmetic purpose or he does not want. If he wants to improve the ptosis, then we can go for surgery in both the eyes, levator resection. And if he does not want because he's staying with this for a long time, then we can go for conservative management.
So is there a test? Is there a test that you can do to determine whether this is bothering him or whether this needs to be corrected, or we can observe it also?
um, I don't know, sir.
Maybe visual field
Okay,
test.
Fields, yeah,
correct.
fields
So
can
you
Visual
be.
can
field test.
perform a visual field test, and if you see that superior hemifield is getting blocked because of this, you need to perform a surgery. Then it becomes a functional surgery.
Right.
But if the visual field is clear, then it becomes a cosmetic surgery.
Okay. Okay.
Okay, so
Yeah.
now how will you manage this case? Like you have posted this patient for surgery. What are the procedures and what will you make sure before operating this patient?
Um, if we plan for levator resection in this case,
Now, what do you think is the best procedure? Whether it's a levator resection?
we can go for a levator advancement also, sir. Because it's a senile
Okay, so
ptosis.
what is the difference between levator advancement and levator resection? So now
I,
this is very tricky.
I think in advancement we just disinsert the aponeurosis from its position inferiorly to superiorly, and in case of resection, we resect it and then suture it to the tarsal plate. Like we are not resecting the muscle here; we are just advancing changing the position of the aponeurosis from inferior to superior tarsal plate, something like that.
Okay, so what is the pathology here? Why has this patient had an involutional ptosis? What is the cause of involutional ptosis?
The degeneration of the aponeurosis, senile
So
degeneration of
it's
the.
not degeneration, it is slipping. So sometimes it is the dehiscence. Dehiscence is when it splits or it becomes thin. The other thing is it slips from its normal, the aponeurosis, it slips. That is why you have a high lid crease. The lid crease is formed by the LPS, which is attached to the skin. So when it slips from its normal position, that's when you will have a high lid crease, as in this patient. So this patient has a very prominent pretarsal show. So you can almost see complete tarsus, and there is a very prominent eyelid fold on the tarsus, which is covering the eyelid crease.
Right.
So whenever there is a slip, then you do a LPS reattachment. So the procedure here would be LPS reattachment. So you just have to expose the muscle and then attach it to the superior border of the tarsus plate, and that will correct the ptosis. So there is no resection in this case. And what are the precautions that you are going to take in this case? Because this is now not a child, so you'll also have to consider a systemic condition, right?
Okay. First is, sir,
So
we'll check.
what
First, we'll check for any to rule out. We'll check for Bell's phenomena and lack of thalamus to rule out. For the exposure, to rule out exposure keratopathy. And from the systemic part, we have to check for, because he's undergoing a surgery, any systemic under local anesthesia or general anesthesia. We have to check for any major systemic concerns, like with a cardiac patient or a whether there are any major systemic concerns for this patient, like ischemic heart disease or a previous, which can be a risk to the anesthetic drug we are using.
correct? And what else? What about the blood thinners?
Oh yeah, yeah, and blood. Yeah, if he's using any blood thinners, that can also, we have to stop that before 5 days, so that to prevent the risk of bleeding during surgery.
Okay, so now I think all of you might be doing cataract surgeries, and it is one of the topic that might be asked in the exam. So you should be very clear what are the newer drugs that are being used, and whether we need to stop them or not, and what is the rationale behind stopping them, and when do you stop them. It is very, very important from this exam point of view. Everybody likes to ask about blood thinners, right?
Okay.
And
Yeah.
for specifically for oculoplasty procedure, pacemakers are very important, because when we are using an electrocautery, we are putting a plate over the patient and the electric currents are flowing. So the pacemaker settings have to be aligned with the settings of the electrocautery machine to use electrocautery. So this is very important. You should not miss this in any patient undergoing any oculoplasty procedure, because whenever the patient is bleeding, you have to cauterize. Whenever you are using a cautery on the skin, you have to be careful that this patient might have a pacemaker.
So in
Right, so
case of,
any elderly patient who is undergoing any oculoplasty procedure must have had a systemic evaluation beforehand.
right. So in case of, sir, pacemakers, should we do the surgery, or we should, or like we should we should
Yes.
not, if the patient is
So you
having a,
have to have a cardiac consult, and if you are planning to use a electrosurgical cautery, then you have to inform the cardiologist, and they will change the setting of the pacemaker so as you can use your cautery. You cannot use it when the pacemaker is still in its. I mean, there are some settings which I don't know, but
okay,
cardiologists have to be informed about it. So be
right,
careful, right?
okay, okay.
Sir, these anticoagulants, the drugs, we should memorize that how much many days we should stop and which medications we should stop, because in routine in our practice we just consult with the cardiologist whether we should stop or not. So should we memorize it, or just
I
can we
think there
say
are
in exam
only,
that I will need a cardiac consultant?
well, for this, I think if you are on a cataract surgery and if they are asking that the patient is taking warfarin and what will you do, and if you say that I will send to a cardiologist before cataract, then it does not look good on your part. So ideally, there are only 5 or 6 drugs, and the newer anticoagulants, I don't think they need to be stopped in cataract surgeries. So you should memorize this, and maybe you can say that I will consult with the cardiologist, but I will stop this or not stop this. It's not like you have to memorize 20 drugs, it's just 5 or 6 drugs.
Yes,
But
right.
overall, I think it's said to stop 2 weeks before, to be on the safe side.
Yes, so older anticoagulants probably 7 days before, but the newer anticoagulants you can even stop 48 hours before.
Oh, okay.
So
Sir,
this is the
please.
patient LPS reattachment surgery. So in this we have done LPS reattachment. The surgery remains the same, the sutures remain the same. It is just the LPS is reattached onto the tarsal plate, the superior border of tarsus. So just to revise everything that we have done so far is, if you have a congenital ptosis, a child less than 5 years, You can observe if the pupillary axis is clear, there is no astigmatism, there is no abnormal head posture. If there is congenital ptosis and there is any of those things, you need to do a sling surgery. If you have congenital ptosis more than 5 years and the poor LPS action, you need to do a sling surgery. Congenital ptosis more than 5 years, LPS action is good, fair, or excellent. Do an LPS resection. In acquired ptosis, always rule out myasthenia and other neurological causes. And if it is an aponeurotic ptosis, you do LPS reattachment. Right? So I think 90% of you will have case of ptosis. So be very thorough how to proceed with this case and what will you do in the exam. Write down your examination points and practice is maybe 10 times before going to the exam.
So this aponeurotic repair is the same, which is LPS advancement, because they say aponeurotic repair with LPS advancement. So LPS advancement is when we disinsert and reinsert at the superior border of the tarsal plate,
So,
right?
so now it is called LPS reattachment. LPS advancement is a name that is written in some books, but it does not make sense. Like, how do you advance it? So when it has slipped, you do
Hmm.
LPS reattachment. Maybe if it is the dehiscence of the LPS, like it has broken down into two parts, one part is down and one is above. Like
Yeah.
some of the old books said after surgery that you can have aponeurotic ptosis. But have you ever seen a patient after cataracts or any intraocular surgery having ptosis? So it does not
Yes,
happen
yes.
anymore. Maybe previous books
Yeah.
that have written that there is dehiscence after intraocular surgery, they might have seen that LPS breaks into two parts and you need to do an advancement of the LPS. But I have never seen a patient with a dehiscence like the LPS has broken down in the center. Like so, LPS
Mm.
reattachment is the correct choice of treatment rather than LPS advancement.
Okay, and this is sometimes steroid induced ptosis also needs LPS reattachment or what? That is
So,
also aponeurotic
steroid,
ptosis, right? Sometimes after
no, that is
long-term use of steroids or after surgery or after uveitis, the person develops ptosis, and it is said that this happens because of this aponeurotic ptosis. The aponeurosis weakening happens.
right. So the cause is the slipping of the LPS, right? I've never seen a patient with steroid-induced ptosis, maybe. So I'm not the best person to tell you this. But if there's a slippage, if there is high eyelid crease, then yes, you should do an LPS reattachment.
Okay, thank you.
Sir, please. I want to ask a question, please.
Yeah, go ahead.
The last case of involutional ptosis, how can I comment on the lower lid? Is it lower lid sagging? Is it drooping? How can I tell? Because a lot of old patients have this sign.
Yes. So this is the lower eyelid retraction. So if you see this first picture, there is a lot of fat pad which is pulling the eyelid down. So if you see these are the fat pads. And there is a laxity of the medial and lateral canthal tendon because of the age. So that is why this eyelid is sagging down. There is no ectropion, but the eyelid is sagging down. So in this case also, after this surgery, he has had done a lower eyelid blepharoplasty, wherein we also tightened his lateral canthal tendon. So we are not discussing that in this, but yes, this is not the normal position of the lower eyelid.
Okay, thank you.
So any question in ptosis? So guys, I had a few cases of lacrimal system I wanted to discuss with you. But what I'm going to do is I'm going to put it on the Telegram group because I have some prior commitments and we have already, done almost 1.5 hours. So if you have any question in the lacrimal system, you let me know. I will put some cases on the group. And if you have any question in the process, maybe you can ask me right now and then we can wind up in next couple of minutes. Dr. Kaushik, are you still here or?
Yes, I'm there, Dr. Ritesh.
So I think all of
Hello.
us are grateful to you, Dr. Kaushik, that you keep on arranging all these classes and put in all your hard work for everyone, arranging all these classes.
No, no. Actually, Dr. Ritesh, this is very selfless of you to arrange this because most of the faculty who have passed, they do not cannot arrange time for this because this is a because there is no honorarium involved and it is actually very difficult to get time from busy schedule of like ophthalmologists. So we are grateful to you for giving your valuable time and definitely we'll request you have other videos also in YouTube. So candidates please see them because from oculoplasty you will have proptosis, ptosis, anophthalmos. These will come and you will have to know. And most of the people fail in oculoplasty and neurophthal. So that is the fact. So you'll have to
Correct.
focus more on this if you are not practicing. Yes, Dr. Ritesh.
Yes. So thank you everyone for joining. And if you have any questions, we can take them on the Telegram group. So thank you.
Thank you.
Thank you. Thank you. Thank you. Good day.
Thank you.
Thank you.
Thank